Welcome to an online program from Parkinson's Community Los Angeles, PCLA. Today we're talking about the latest developments in deep brain stimulation for Parkinson's disease. And I want to emphasize the contribution made to us by our sponsor, Abbott. We're very grateful for that in making this possible. I'm Stephen Rubin, a member of the PCLA board. My connection with Parkinson's is through my late wife, who struggled with Parkinson's for many years. During that period, she had deep brain stimulation, which provided her significant relief for a substantial part of that period. And I went through that experience with her. And I know the importance of deep brain stimulation, the contribution it's making to Parkinson's treatment, and the incredible, and I say this having seen the trajectory of deep brain stimulation, the incredible advances that are now being made in the process. I speak for myself and personal experience, but I'm very excited that PCLA is sharing this program with you, and especially as PCLA does have its roots in the Los Angeles community, that we are able to bring information from top centers, and certainly USC is among the nationally renowned centers for movement disorder, but is a local institution, and Los Angeles is really gifted with the amount of deep brain stimulation and more generally movement disorder specialists that we have. I know from past programs that there's going to be a number of you that don't live in Los Angeles. In fact, we've had viewers from around the world. But know that the information you're going to get today is scientific. It applies everywhere and at all times, and is available for those of you who have access to Los Angeles. It's available here. One of the things that PCLA does is provide these kinds of programs and the resources that come from the Los Angeles community. And this is a special aspect of what we do, a unique aspect. And the speakers, presenters we have today are among the best that you're going to hear from. Before we start, there are always Zoom ground rules and rules for our program. Know that we're recording the event today for a possible posting on our YouTube channel, which also means that if you want to go back and rehear portions or all of it, it'll be available to you. If you don't want to be visible in the YouTube recording, you just turn off your video. Please stay muted so that we have a clear soundtrack for this. We've planned for time at the end of these presentations for you to ask questions. And during the presentation, you can submit them in the chat function. We also appreciate, given the nature of our calling and Parkinson's disease, that some of you may not be able to type. And there is going to be a facility also for verbal questions at the end. And as always, keep your questions focused on today's topic of deep brain stimulation in Parkinson's. As I mentioned, we have, and we're excited about our presenters, all from the University of Southern California and the Keck School of Medicine. They're in the Department of Neurosurgery. Dr. Brian Lee is the Director of Stereotactic and Functional Neurosurgery. Dr. Darren Lee is Assistant Director of the USC Neuro Restoration Center. And Dr. Mark Leiker is Associate Clinical Professor in the Department of Neurosurgery. So without more from me, thank you, doctors, for joining us, and we'll start our presentation.
Okay, can everybody see my slide okay? Yeah, all right. Well, I want to thank the PCLA for putting together this wonderful presentation, for inviting our USC DBS team to come and speak with everybody. I'd also like to thank Abbott for supporting this presentation. So I'll be going first. My name is Dr. Brian Lee. I am the Director of Stereotactic and Functional Neurosurgery at USC. I'll first give an introduction to DBS and also talk about a sleep DBS surgery. This will be followed by Dr. Mark Leiker, who will talk about awake DBS surgery. And then this will be wrapped up by Dr. Darren Lee, who will be talking about new indications for and new advancements in DBS surgery. So to go ahead and get started. This is a video of a patient who has severe Parkinson's disease. Many of you may be familiar with some of the symptoms that he's having. You can see the tremors that are in both his hands and his legs. He is off medications right now, and you can see that he is quite dyskinetic with a significant amount of tremors. This was one of our evaluations before deep brain stimulation surgery. This is the same patient after surgery. You can't really see the scar on his forehead, but you can see that he's significantly improved. He is back on his medications, and the DBS has been optimized. And in this case, you can see that his tremors under much better control, and he is feeling quite well. So DBS can make a very dramatic difference in the patient's daily life. So just to review briefly, as many of you know, Parkinson's disease has significant motor components. And when we talk about the motor components, we talk about stiffness, which is sometimes referred to as cogwheel rigidity, slowness, also known as bradykinesia, and a resting tremor, as opposed to an intention tremor that you may find with essential tremor. The onset of this motor dysfunction can be asymmetrical. You may have one side start before the other side. You can also have dyskinesias that come with Parkinson's disease, and oftentimes this is related to the medication that you take. And these can induce, the higher levels of dopamine can induce dyskinesias. Parkinson's disease can also be associated with dystonia, which is cramping and contractions of different muscle parts. This can be found in the neck, but oftentimes is found in the feet as well. PD is also related to gait problems, including shuffling of gait, freezing, and also unfortunately falling. However, Parkinson's disease isn't just a movement disorder. Parkinson's disease is associated with depression. Up to 80% of patients may have signs and symptoms of depression. It can also be associated with anxiety, loss of smell, constipation, sleep disorders, incontinence, low blood pressure, and also memory problems and dementia. Now, the majority of patients who have Parkinson's disease will first be started on medication, and levodopa is the gold standard treatment. Now there are a significant number of additional medications that work via different mechanisms to treat the symptoms of Parkinson's disease. However, levodopa is still the gold standard. And for the majority of patients with Parkinson's disease, levodopa or some sort of medication is going to be all that the patient needs throughout their lifetime. This is a figure that demonstrates the on and off progression through Parkinson's disease through a typical day in the early stages of Parkinson's disease. The blue line represents the total dopamine levels, and when the levels are high, the patient is on, right? Where the symptoms are well controlled, you have therapeutic benefit. And when the blue line drops, that's when the patient is off. where they start to have the symptoms, the rigidity, the stiffness, and the tremor. And so you can see that that window is denoted by the TW, or therapeutic window. Early on in Parkinson's disease, this therapeutic window is quite large. You take medications a few times a day, and you can stay on within the therapeutic window quite easily. However, as the disease progresses, this happens where the therapeutic window becomes smaller and smaller. And then this is where you also start to get motor fluctuations. And you can see that that green line, which represents the total dopamine level, starts going up and down. And so in order to try to be therapeutic, you have to take higher doses and at higher frequencies. And this can lead to dyskinesias and what we call motor fluctuations, where when you need to take the medication more often, but by taking it more often, you also take higher doses. And then when you take higher doses, you end up with dyskinesias. So you can never really get good control of your symptoms, and you can't stay in that therapeutic window in the on condition. So this is when we start really thinking about deep brain stimulation. So deep brain stimulation is something that's been around for about 25 years now. I like to think of it as relatively new and cutting edge. However, the technology has been around for several decades. It was first approved for essential tremor and Parkinsonian tremor in 1997. And then it was approved for Parkinson's disease in 2002. It has since been used for dystonia and also has conditional approval for other diseases such as obsessive compulsive disease, OCD. DBS has three main parts. There's the part that goes into your brain. That's the most important part. That's the part that we target to specific targets in your brain that are involved in Parkinson's disease. We then have a lead extender that comes down your neck, which is the connection between the lead in the brain, and then a generator that is implanted just below your clavicle in the skin. So it's completely under the skin and not visible. The entire system is fully implanted. There's no external component. Because it is completely implanted, most patients find that they can live their lives pretty normally. They can swim, they can walk, they can exercise, they can do their activities of daily living without any complication. The systems have evolved over time. Initially, we had primarily one DBS company. Now we have three manufacturers of DBS systems, including Abbott. This is a picture of their system showing the different devices that they offer, and also the programming tablets on how your physician and surgeon can communicate with the device through a wireless telemetry device. The most important part, as I mentioned earlier, is the part that goes into your brain, or the leads. Initially, the leads were in only 4 contacts, and this allowed the physician to pick the correct contact at the specific part of the brain that you needed the stimulation at. And this is how it's been for about 20 years. However, one of the biggest developments is the development of something called directional leads. So instead of stimulating in a ring around the lead symmetrically, now we can stimulate in different segments of the lead, and this allows us to stimulate specific parts of the brain without causing side effects in other parts of the brain. This is an example of such an indication. The red circle is a cross-section view of the lead, and you can see the lead is broken into 3 pieces labeled 2A, 2B, 2C. Now, the goal of this lead is to try to stimulate the STN, which is the subthalamic nucleus. But at the same time, we don't want to stimulate the structure labeled IC, which is the internal capsule. If we do stimulate the internal capsule, this can cause side effects. And so by having a directional lead, we can selectively stimulate, for example, contact 2B and not stimulate 2A or 2C, which could cause side effects. This allows for us to have more customization and individualization for each patient's unique brain anatomy. Now, DBS is not something that we put in, do the surgery lightly. We actually have to have a lot of people involved, and the DBS team is quite extensive. At USC, we're proud of the fact that we have a comprehensive DBS team. The main person in that team is the patient and their family, because this is not something that somebody can deal with alone. They have to have a support system that can help them come to appointments, deal with surgery, recover from surgery, come to the programming sessions. So it's the patient and their team. We also need to involve the primary care provider, a movement disorder neurologist, a neuropsychologist, a psychiatrist if needed, a neurosurgeon, anesthesiologist, DBS programmer, and a list of other team members to make sure that DBS is the right therapy for you. And once you get the DBS system, to make sure that you have the full support to maximize the benefit of the DBS system in controlling the symptoms of your Parkinson's disease. Now, for Parkinson's disease, who should get DBS? That's one of the big questions. And as I mentioned earlier, not everybody who has Parkinson's disease needs DBS. We estimate that the vast majority of patients will do fine on medication. However, for the 15 to 20% of patients who have difficult cases, DBS can provide significant relief. So one of the key things that the patient must demonstrate is that their Parkinson's disease is responsive to levodopa, and that their Parkinson's disease is not adequately controlled with medication. Okay. The patient should also have minimal cognitive impairment. As we know with Parkinson's disease, you can have neurocognitive decline over time. And so if there is severe decline, then the patient may not be a good candidate for deep brain stimulation. The targets for implantation are the subthalamic nucleus, or STN, and also globus pallidus interna. And it's part of our team. It's important for our team to work with you to figure out what is the best target for implantation. Now, the risks of DBS include bleeding, 3 to 5%, infection, also 3 to 5%, possible cognitive decline, and also mistargeting. Now, let's talk a little bit about DBS surgery. Now, during surgery, you can either be awake, which is the traditional way of doing DBS, or you can be asleep. Being awake with microelectrode guided DBS lead placement is the technique that's been around for several decades and is quite effective. However, we have a newer technology called asleep real-time ClearPoint MRI guided DBS lead placement, which is an alternative to awake surgery. Now, these are not competing techniques, but these are complementary techniques depending on each patient's needs. Regardless of which technique you need, the goal of surgery is to put electrodes very accurately at very precise locations in the brain. In this case, the red dots represent GPI, which is a part of the brain that is deep in the basal ganglia, and whereby stimulating these targets, we can improve the motor symptoms of your Parkinson's disease. We also get an MRI of the brain using contrast so that we can make sure that we don't hit any of the blood vessels. So the following talk by Dr. Leiker will talk more about the awake technique. Here, briefly, I'm going to talk about the asleep technique. In the sleep technique, we use MRI guidance to determine where the lead is going to go. This is real-time imaging of the brain, the lead, and the target. And we perform the entire surgery inside the MRI magnet. This allows us to put the patient under general anesthesia so that they don't have to be awake during surgery. And instead of having the patient participate in the surgery, we use the MRI guidance and direct visualization of the brain targets to figure out exactly where we need to be. Now, this is a good option for patients who have severe anxiety. or patients who have severe tremor and they don't think they can hold still during an awake surgery. For patients who can't hold their medications overnight, that is required for awake surgery. Other patients who have concerns about speaking during surgery. For example, we have several patients who don't speak English as their primary language, and they're concerned about having to converse with the surgeon in the operating room. And so they'd rather be asleep and not have to undergo awake surgery. And also finally, with patients who have severe dystonia and contractures that can preclude comfortable positioning in awake surgery. And so during awake surgery, we have this frame that we place on the patient's head, which is on the left, which Dr. Leiker will speak more about. During a sleep surgery, we use a mini frame that is MRI compatible, and we do the entire surgery inside the MRI scanner. Here are some images showing the MRI images of my plan when we're doing the surgery. I can see the different targets and I can place the electrodes very precisely, and also more importantly, confirm that the electrodes are exactly where I want them to be. Here is another view showing where the electrodes are, and that I can, once I put them in the brain, I can get an MRI scan and see that they are on target and if there's any deviation. The goal is to have the DBS leads within less than 1 millimeter of error. So these are very, very precise techniques. Here's a picture of the MRI scanner where the anesthesiologist is putting the patient to sleep and positioning the patient on the MRI gurney itself. And then you can see that the patient is intubated, so they are entirely asleep throughout the entire surgery. We do the surgery inside the bore of the magnet at the back of the magnet, and we turn the back of the magnet into a operating room. And inside the control room for the MRI, I can then plan our target and then also get real-time imaging of the surgery. Here's another picture of one of our physicians making some adjustments on the trajectory. And I know this is hard to see, but here we can put the DBS lead into the brain and confirm the location, and everything is sterilely draped. Now, this technique has been around for over a decade, and there's been many studies, because one of the questions I get a lot is, well, is awake better or is asleep better? And the answer is that they're equivalent. It's up to the patient. Studies have shown that both awake and asleep DBS have equivalent clinical outcomes, which is the most important outcome. They also have equivalent infection outcomes because since we're implanting hardware into the body, getting infections is a big concern. And so it's good to know that studies have shown that we have equivalent infection outcomes. So ultimately, it's a personal preference between awake and asleep DBS surgery. At USC, we're proud to say that we're the only center in Southern California that offers asleep MRI guided surgery. You can see that there are several centers across the country, from UCSF to Harvard to Emory, that do offer this same technique, but we're the only ones in Los Angeles that offer MRI guided asleep technology. So in summary, DBS is an effective treatment for controlling the motor symptoms of Parkinson's disease. DBS can be placed in the brain using traditional awake microelectrode guided techniques, or the newer asleep real-time MRI guided technique. And it really depends on the patient's preference. This is my email and office number if any of you want to reach out to me. I thank you for your attention, and we'll go ahead and move on to Dr. Leiker's presentation.
Okay. Let's see. All right, thank you. Can everyone hear me?
Yes, very good.
Yes. Okay, great. Thank you, Dr. Lee, and thank you, everyone, for allowing us to present our experience with deep brain stimulation. So I'm going to talk about the awake procedure, which is the one that's been in existence for well, pretty much forever, since DBS has come onto the scene. I've been doing DBS for about 20 years now at USC, and have seen a number of changes, and I'll talk about that. But the main change that I'd like to highlight, really for the patients, is that there's a level of comfort now that didn't exist 20 years ago from the patient's perspective with regard to the procedure. Early on, question, are the risks really high, and isn't there going to be a stem cell technology? Isn't there going to be a new medication that's going to cure Parkinson's? And stem cells for Parkinson's so far has come and gone. There's some other novel technologies, but DBS is tried and true. And so we have a long experience at USC. Even before I started 20 years ago, implanting DBS, we have patients that go back 24 years that are still being seen at USC, still being seen by our nurse navigator, Nazrin. So this is an old slide, just gives you a sense as to what we're doing. So we're implanting this electrode in the brain, in a specific target. Everything is under the skin. These are very comfortable technologies now. We understand pacemaker technology. Many people have implants nowadays. It's extremely common. The electrode itself is quite small. And since I'm discussing awake DBS, I'll talk about microelectrode recording. So you can see the electrode on the two electrodes on the left. The upper one is the older electrode. We use a variety of new electrodes now, including the Abbott technology. And the lower electrode is the recording technology. For those of you who recall what a record player is, it's like a needle for the record player that allows us to listen to the neuronal output, to listen to the cells of the brain while we're doing the procedure.
Dr. Lecker, I'm not seeing your slides. Have you shared them on screen with us?
I thought I did. Apologies. Here. Is that it?
Thank you.
All right. Okay, so start at the beginning here. This is the opening slide. This is the electrode. The upper one is the permanent electrode to stimulate the brain. The lower one is the recording electrode that I discussed, like a record player needle. So there's been a lot of research over the past. You can see the number of publications, and there was a dramatic increase once the FDA approved deep brain stimulation for essential tremor in 1997. This only goes up to 2011, but the numbers are exponential. So I'll talk about how we do what we do in the awake procedure. And fundamentally, the idea is we're merging different technologies, merging our understanding of neuroanatomy and neurophysiology and the underlying pathology of Parkinson's disease to optimize the outcome. So DBS has been approved in the US for Parkinson's disease, essential tremor, dystonia, and OCD under a humanitarian device exemption, and also epilepsy, which is a newer indication. It's also approved for the same in Europe, and we've been through multiple different investigations over the years into different pathologies, and hopefully we'll have some new indications coming out in the near future. What are we targeting? We're targeting this extrapyramidal system, which originates in the substantia nigra, which is a part of the brain that produces dopamine. We lose dopamine, and that changes the integrity of the system. The output of this system is motor function. So when you change this abnormal circuit, when you change the circuit, it changes the presentation of the end product of that circuit, which is motor function or movement. How does DBS actually work? We're still understanding it. And, we kind of like to joke that we really don't understand how DBS works. We have some inkling, but it's almost like, a blind person trying to understand, that there's an elephant in front of them by feeling the tail and the tusks and the leg. We're getting different pieces of it through all the research that people are doing. So the fundamental concept at this point is that there are abnormal oscillations in the brain, which are called beta oscillations, which are low frequency. You can see in this chart, when we turn on the DBS, we alter that abnormal frequency. We stabilize it to a higher gamma frequency. You can see where that red bar is in the diagram. Before and after the red bar is turned on, that's the DBS stimulation. We have this low frequency beta oscillations, which somehow contributes to the pathology of Parkinson's disease. So what do we actually do in the brain? So this is just a plain X-ray of the skull, and you can see the two electrodes in the brain. This is what we want to see after surgery. So there are various stages to this. We use an MRI. We also use an intraoperative CAT scan, essentially an intraoperative imaging technology that shows us where the electrode is in the brain. We implant the lead. We verify the lead location, and that's why we need the patient to be awake during that part of the procedure. And once we're comfortable that the electrode is in the correct location, we secure it and close. The awake procedure is done with the patient mostly asleep, but awake whenever we need to verify location. So the patient may only remember a very small portion of the surgery. Abbott, since Abbott is sponsoring this, I thought I'd mention that really what they've been able to provide to us as neurosurgeons is an opportunity to direct the stimulation. You saw the electrode that I was presenting before. There's a solid band of metal around the wire, around the electrode, and all the electricity emanates from that band in a circumferential direction. So it stimulates everything around the electrode. What Abbott was able to offer is directional stimulation, so that if we wanted to stimulate in a certain direction and avoid a pathway or a structure that would cause side effects, we can therefore do that. So that's extremely helpful in the event that we're not quite on target. Some general intraoperative concepts here. The patient's head is secured, and the patient is asleep when we do this. And again, only is awakened during the testing part of the procedure. So this is a very comfortable, I know it looks uncomfortable, this frame, but it's actually very comfortable position that the patient's in. We try to expedite the procedure because when the patient's awake, they may have some muscle cramps, they may have some neck tightness. And so we want to make sure that we're in the right location before we leave the operating room, but that we don't take a long time to do that. This arc and frame allow us to navigate specifically to the right target. This is an image of not the same patient, but a different patient. You can see the arc that I just described. There's a microelectrode drive that's attached to that, and we advance the electrode on a sub-millimeter basis through brain tissue to identify where exactly we are in the brain. So we can hear the output of the neurons as we're advancing this wire, a record player wire through the brain. I mentioned the O-arm, which is the intraoperative, like a CAT scan that gives us a very nice image of exactly where the electrode is in the brain. We can use that image, merge it with an MRI image that we have preoperatively, and confirm that the electrode is in fact in the correct location. So this is another schematic. We use a navigation system called the Stealth, and we design the trajectory, and then we confirm that we can match the trajectory to the actual implant. So these microelectrodes are very helpful to identify where we are. So this is just a schematic of the brain. In this case, we're targeting the globus pallidus, which is one of the targets we use for Parkinson's disease. And we can see that there are other structures around, like the optic tract, the internal capsule. We don't want to place the electrode there because the patient will have uncomfortable side effects. So as we're advancing that record player wire through the brain, we can identify the patterns of output of the different neurons and confirm that we're in fact in the right location. So what we hear when we're in the globus pallidus externa GPE, very different from what we hear when we're in the globus pallidus intern, and therefore confirm that we're in the correct location. And we can also test the patient by moving their joints. We can identify, again, where the electrode is located in the right nucleus. Once the electrode is, we confirm it's in the right, we feel comfortable it's in the right location based on the neurophysiology. We can then awaken the patient and test the electrode to confirm that the electrode is in fact in a good location, and importantly that there are no side effects. So we attach a pulse generator, a device that acts like a battery and sends a current into the electrode to confirm that the patient is getting benefit from the stimulation and having really minimal side effects. If we do see side effects, we can identify where those side effects are occurring in the brain, which structure we're stimulating, and then move the electrode away from that structure. So the side effects, for instance, if the patient has difficulty speaking with the stimulation, or have contractures of their arm or leg, then we know we're too close to the internal capsule, and we would have to move the electrode away from the internal capsule, which is a large band of axons that travel from the brain to the spinal cord. We use different anesthetics to make sure that the anesthesia isn't affecting our ability to record the neurons in the brain, and also make sure that the patient's comfortable, and then when necessary, have the patient awaken. So some of the outcomes, these are very nice images. So this is a patient with a central tremor. We asked them to draw these spirals before surgery, and then after the stimulator is implanted. So the two diagrams on the left, the one video and the one diagram, indicate the spirals that the patient's attempting to draw. And on the right, this is after the stimulator is implanted. So let me turn on the video. It's a very short video, but you can see the movement of the background. The image on the right is actually a video, not a photograph. And so the patient's tremor is dramatically improved. I began using Google Glass, which gives the video a bird's eye. It gives the viewer a bird's eye view of what's going on. So I don't know if you can hear my voice, but I'm wearing a set of glasses with a video camera on them. And so we're testing, in this case, this is a patient with Parkinson's disease who has very difficult contractions in his leg, dystonia of the foot. And so let me play that again so you can see he's having a lot of difficulty elevating his foot, dorsiflexing his foot. You can see the range of his extension of the extension of his foot. This is after stimulation. See dramatic improvement. So we know that we're in an excellent location. Patient, you can see, is awake, he's comfortable, and we're getting great results with the stimulation. just mentioned, we do treat children as well. This is a specialty that's fairly uncommon. Left is before surgery, right is after surgery. Dystonia is not only seen in pediatric population, but also, for example, the gentleman that we saw in the previous slide who had foot dystonia. Different type of expression, but we call it dystonia. So dramatic improvements. In the pediatric population, we also place multiple electrodes to get excellent neurophysiology as to the appropriate target for children with dystonia. So we placed a lot of electrodes at USC. I think this is mostly my experience. And this includes the temporary electrodes that we use in the pediatric population. But overall, we have a very low rate of hemorrhage. Our infection rate is very low. Very few fractures or lead migrations. And so overall, it's a very safe procedure. So DBS is very effective for patients with movement disorders. And the risks of surgery, because of the experience that we have, because of the technology that we use, we've been able to really minimize the side effects and the complications and maximize the efficacy of the intervention. Thank you very much.
Thank you. Dr. Lee?
Great, thank you. Let me just pull up my slides. Okay, can everybody see this okay? Oh,
Yes, very good.
okay, great. As mentioned, my name's Darren Lee. I'm also an assistant professor at USC. At this point, I don't have any disclosures. A brief overview on my topic is going to be kind of deep overview on deep brain stimulation, which will go very briefly since Dr. Lee and Dr. Leiker have already kind of gone over that. And some of the kind of new indications and advances in DBS over the last 10 to 20 years. As previously mentioned, there are a number of kind of indications for deep brain stimulation. Most predominantly, it's Parkinson's disease, and we've talked about some of the targets in the brain that we use for PD. Also, essential tremor and epilepsy are the FDA-approved indications. And then there's also FDA human device exemption indications like dystonia and obsessive compulsive disorder. As Dr. Leiker mentioned, there's a number of also exploratory potential indications for deep brain stimulation like Alzheimer's, depression, Tourette's, PTSD, addiction, pain, schizophrenia, and a number of other indications that have been explored. As Dr. Lee and Dr. Leiker previously mentioned, Parkinson's disease, as you well know, is a chronic progressive neurodegenerative disorder. A lot of research has been done looking at the influence of the basal ganglia in Parkinson's disease, as well as this kind of degeneration of the dopamine neurons. And as such, the primary treatment has been medications, largely to replace that dopamine neurotransmitter in the brain. And as mentioned before, the predominant features, and most time people think of PD, they think of the motor features, the slowness of movement, bradykinesia, the tremor, the rigidity or stiffness. But again, as mentioned before, there's a lot of other non-motor symptoms, like the postural and gait disturbances, some of the cognitive changes, and then other processes like sleep or speech, swallowing, can also be effective. And deep brain stimulation is generally really only good for the motor components, not so much these other non-motor symptoms. And so that's some of the kind of advances in research that I'll be discussing shortly. So as previously mentioned, again, first-line treatment is for PD are these dopaminergic medications. And we target either the subthalamic nucleus or the globus pallidus, part of the basal ganglia, with deep brain stimulation, but really to try to kind of improve these motor symptoms. Um, so as we mentioned, that some of the kind of recent advances in deep brain stimulation have been kind of a wide range of components, from the surgical targeting, so how we actually put the electrodes into the brain. There's more advanced imaging, like this functional MRI, or things that looking at the actual tracks that we're trying to stimulate, and using those as our kind of uh, planning for targeting, as well as potentially new research suggests that we might be able to use these post-operative imaging to help better program the deep brain stimulation. There's been also advances in the batteries themselves. So with any electrical device, batteries don't last forever. But there's been improvements in battery life, as well as the introduction of rechargeable batteries, or I guess non-invasive rechargeable batteries. The ability now to get MRIs before with these batteries, patients with deep brain stimulation couldn't get an MRI, but now they have the ability to do so. Some in kind of the standard MRIs, and then some now in the more kind of advanced MRIs, like 3T imaging. There's also been kind of advances in how we actually can program. So there's typical stimulation parameters, usually they're high frequency stimulation parameters, but as you know, patients can differ throughout the day, or even throughout months. And so we can now offer multiple different programs that a patient can kind of cycle through to best meet their needs. There's also these concept of potentially interleaving of the different stimulation parameters to improve outcome. And then there's now the possibility as well to do potentially remote programming. So initially with DBS, you'd have to come into the office and then have your DBS device changed. Now we have this ability to do this, especially in the time of COVID and video telehealth, doing this so that you're not actually in person. And then, as previously mentioned, there are these improvements in the leads themselves. So we can, with the directional leads, basically steer the current or steer where the stimulation goes to avoid adverse side effects. And lastly, there's been changes in the number of contacts. So on each of the leads, there's a certain number of contacts. And with the increased number, we have a little bit better ability to target exactly where we want to be. As I mentioned before, some of the new advances are really patient-specific programming, looking at basically actually seeing where the electrodes are, or where the leads are, to try to avoid the side effects, and using, again, imaging, either structural imaging or the actual activity in the brain to guide where we want to program. Future directions could potentially also be things like machine learning to better narrow down what your or the specific patient stimulation parameters are. So as I mentioned before, Parkinson's disease and DBS is really aimed at the motor components, again, rigidity, bradykinesia, and tremor. But a number of other cognitive processes are also affected in this kind of globally neurodegenerative process. Things like verbal fluency, executive function, things like memory can also be affected. And in a certain number of patients, it can eventually go down the route towards mild cognitive impairment. So something that we're interested here at USC is looking at seeing if we can alter the stimulation parameters to potentially actually improve or help some of these other symptoms. So the traditional deep brain stimulation strategy uses high frequency stimulation, so like 100, 180 hertz, so very fast stimulation parameters. But there's significant evidence to suggest that low frequency oscillations are important in various cognitive processes like learning and memory. So some of these like low frequency, like 5 to 12 hertz oscillations in the brain are important for that. Moreover, in some of the targets that we use, like the subthalamic nucleus, different parts of that structure are important in different aspects of behavior. So the top portion, or the dorsal portion, is important in a lot of the motor components, but some of the lower parts or ventral parts of the subthalamic nucleus are thought to be important in things, some of the more associative or cognitive and emotional components. And so targeting or stimulating the correct part would be potentially important for either the motor components or potentially even some of the cognitive components. So we did a study here at USC, at USC, looking at patients with deep brain stimulation leads in the subthalamic nucleus. And what we wanted to do is see if we could alter the, or improve some of the cognitive components with this low frequency stimulation compared to a standard high frequency stimulation. And so immediately after surgery, we had these electrodes in and we tested these stimulation parameters. So we looked at low frequency stimulation versus patients, a kind of standard high frequency stimulation. And what we found was actually that we could actually improve patients' verbal fluency with this low frequency stimulation, as you see here on the left. But however, this was specific to verbal fluency, as some of the other cognitive tests, there were no significant changes. So based on this study, we actually kind of proceeded to look at patients who had been chronically implanted with deep brain stimulation. And again, we wanted to look at, do a similar study looking at various sorts of cognitive tasks. And here we looked at either a no stimulation paradigm, a low frequency stimulation paradigm, or the theta stimulation, or high frequency or gamma stimulation. And again, what we found was that patients using this low frequency stimulation actually had improvements in their verbal fluency. Now, the problem with just giving patients low frequency stimulation is that it doesn't actually help the motor components. And so that's why it's important that we have some of these newer devices that can actually interleave this low frequency oscillations with high frequency, so we could potentially use both low and high frequency stimulation concomitantly to potentially improve both the motor and cognitive components. So right now we're actively enrolling patients at USC with patients who have already implanted DBS devices for Parkinson's to see if we can potentially improve both the motor components as well as the cognitive components of Parkinson's disease with our stimulation paradigms. Now this is a little bit kind of deviation from Parkinson's disease itself. But as we previously mentioned, that there's a number of potential other indications for DBS. And one of the exploratory ones is Alzheimer's. And the reason why I thought that this is important for this particular talk is because a number of patients with Parkinson's disease can develop mild cognitive impairment and dementia, similar to that of Alzheimer's disease. And so there's currently so Alzheimer's disease is a neurodegenerative neuropsychiatric disorder that affects a lot of cognitive processes. And there's been exploratory DBS, deep brain stimulation for Parkinson's disease, initially a couple of phase 1 and phase 2 clinical trials. Now there's a significant data that suggests that there's brain circuit dysfunction in Alzheimer's disease, with evidence using EEG, MRI, and kind of some PET, or kind of that shows differences in metabolism in the brain. Now, this, even going down this route, was basically a chance observation. There was a patient undergoing deep brain stimulation for obesity, and as they were passing down the electrodes, you stimulate as you pass them down. And as they did this, they noticed that this particular patient noticed that they had recollection of memories that happened many, many years ago. And this stimulation was reproducible in this particular patient. And they noticed that there were improvements targeting this specific region called the fornix in a number of like neuropsychological assessments. particularly with kind of some spatial learning and verbal learning tasks. Stimulation, they saw that not only could they stimulate that particular pathway, but it activated other regions of the brain. So it's not just a focal activation of the bundle pathway, but other regions of the brain that are important in learning and memory. Additionally, they have so in Parkinson's, in Alzheimer's disease, there's generally kind of reduced activity or metabolism of the brain. But when they used DBS of the fornix, they had increased activation in regions of the brain thought to be important in Alzheimer's and these kind of memory or cognitive losses. So that led to a 42 patient phase 2 study where they initially saw that it was a kind of randomized study that didn't really show a significant change in their Alzheimer's patients, but they did know this in a subset of the patients, that the older group, those patients older than 65, that decline in mental status didn't occur nearly as fast as the decline in the younger patients. So at USC, we're actively recruiting for a phase 3 clinical trial for deep brain stimulation for Alzheimer's disease, where we're trying to determine both safety and efficacy of DBS for Alzheimer's disease, where we're looking for patients basically with mild AD and over the age of 65. With that, I'd like to thank all of my collaborators at USC and our DBS team, and be happy to take any questions. Thank you so much.
Thank you, Dr. Lee, Darren Lee, and thank you, all of our 3 participants. Again, speaking from my own experience, this was as comprehensive a presentation as I've experienced, and I'm grateful on behalf of PCLA for your participation, and grateful again to Abbott for assisting us. Let me see, I believe we have a question, a written question. Is DBS also performed in other Parkinsonian patients like PSP or CBD, etc.? Maybe Dr. Brian Lee, since you gave us the broad sweep, you could tackle that question first, and if the other doctors wish, they can add to it.
Yeah, so DBS is not currently used for PSP. It is being used for additional studies, as both Dr. Leiker and Dr. Darren Lee mentioned. But the official, again, not everybody with Parkinson's disease needs it. So when you have other types of diseases that are not Parkinson's disease, but similar to it, those are generally not candidates for deep brain stimulation. But the best thing to do is to meet with your movement disorder neurologist, who can evaluate you carefully to see if DBS is something that will help you. The last thing we want to do is put in a device and have the patient undergo a surgery that we don't think is going to help very much. But the best thing to do would be to meet with your movement disorder neurologist.
Thank you. Dr. Leiker, this second question may be for you as the surgeon with experience. I'll read it for everyone. This is from, I don't know if I'm going to pronounce it correctly, Suhair Kwaborsi. My question is regarding DBS for one side versus 2 sides. From your experience having the second side done, does it improve overall results of DBS, including the first side that was initially done?
Yes, very good question. We discuss this fairly often because Parkinson's is a bilateral disease. the loss of dopamine and the effects of that affect both sides of the body. Patients do present with greater degree of symptomatology on one side versus the other. And so we do have patients where we say, maybe it's a reasonable idea to implant the one side alone, but those are the rare patients. Because it's a bilateral disease and a progressive disease, the patients will require bilateral stimulation. So we err on the side of providing the patient with bilateral implants. I think we all do that at the same setting. So we generally place both electrodes at the same setting. And so the procedures are a two-stage procedure. The first stage being bilateral implants in the brain, and the second stage being the implantation of the battery. My experience with some patients who may have some cognitive impairment, but do require DBS, we do stage it. My experience is that placing both electrodes at the same setting has a higher risk of the patient experiencing some short-term cognitive decline, which recovers. And so patients with that's why we do neuropsych evaluations for all patients. Patients with some cognitive decline, cognitive difficulties before surgery, as long as they're mild, we might consider implanting a unilateral stimulator, followed up a few weeks or a few months later with the contralateral side. But in terms of the symptomatology, really going back to your question, patients with Parkinson's do better with bilateral stimulators. We do know that there's a contralateral effect, which is predominant. So right-sided stimulator improves the symptoms on the left side of the body, but a right-sided stimulator will also improve symptoms on the same side of the body. We especially see that in the tremor patients, where say a tremor of the right arm benefits from a stimulator on the left side of the brain, but it also benefits from a stimulator on the right side of the brain, perhaps 10% or so. So overall, if we can, we err on the side of implanting bilateral stimulators. I'll leave it to Doctors Lee to add any other comments that they might, if it varies from mine.
I think you did a great job on describing it. Of note, you can program each of the different sides differentially, and so they don't have to have the same exact. Putting it in doesn't. It gives you more options.
Yeah, exactly.
Thank you. I should say the first question I failed to mention came from Shanta Patel. Our third question is from James Roars. Do you coordinate with the West LA VA Hospital? Perhaps Dr. Brian Lee is the director. You could respond to that one.
So at this point, we don't. It's the West LA VA. I'm not sure who they are affiliated with, but my understanding is they do have DBS there, and I'm sure you would get excellent care there as well. But if you want to make sure, you can always call our office, and we're happy to check for you.
I should mention, I'd like to mention actually that to augment that I believe that the VA insurance now does allow patients to go outside the VA system. So for those patients who have the TRICARE, I'm confident, although I'm not going to check on that, but I'm confident that we do see TRICARE patients at USC.
Thank you. Mr. Roars came back and said, I am on track for DBS at the VA. So I guess that is in the works. Pi Reet, again, I don't know my pronunciation is correct. I apologize if not. Writes as to symptoms: stiffened stomach, feeling cramp in stomach. Is that a common symptom of PD? Does DBS help? Of course, the doctors have not examined anyone these are not medical opinions, but perhaps they could respond to that. Maybe Dr. Darren Lee, do you want to take first shot at that?
Sure, sure. I mean, so PD definitely has a lot of autonomic effects, so it could definitely be related to Parkinson's disease. However, as I mentioned before, DBS is not usually beneficial for the autonomic symptoms. So I don't think that DBS would really have any significant effect on kind of the cramping in the stomach. More of the rigidity, bradykinesia and tremor are more of the motor symptoms as opposed to a lot of the internal organs.
Thank you. Next question is from Jay Gately, and question I'm sure is welcomed by research institutions such as Keck Medicine. How does someone get involved with your studies with patients who have had DBS? Maybe start again with Dr. Brian Lee and go down the list.
So I would, actually, I'm going to defer this to Darren. Darren is actively recruiting patients. So Darren.
Okay.
Yes. So as we mentioned, we're doing a number of kind of DBS studies in patients with DBS for Parkinson's disease. I can leave my email in the chat here, and I'd be happy to, if you want to email me, I can definitely get back to you as we recruit and have, I'll reach out to you personally at that time if you send me an email. I'll put that in there right now. And then we can discuss more the details of the study at the time.
Thank you. Mr. Roars, again, I understand way they perform MRIs now also require additional blood lab work. I know that seems to be a statement rather than a question. If Mr. Roars wants to turn it into a question, we could do that. Let me go to Jason or Apollo. Let's see, just wanted to let you know that Dr. Zanos Mason, the neurologist from USC, is also on the Zoom and is available, for any neurology questions. Thank you. This is one of the representatives from Abbott. I don't know, Dr. Mason, do you have anything to add at this point?
No, not. I've been in the background just to introduce myself. Hello, everyone. I think I was on a presentation a couple months ago that many of you might have attended, but no, the answers have been thorough and excellent. And happy to be here and happy to meet you all virtually.
And I concur, and thank you for coming in. Dr. Lee has sent out his contact email. And Mr. Roars has come back and said yes. So I think that, and we're running late in time, so let's conclude the chat. Is there anyone who was unable to participate by chat who would like to ask a question orally? If so, unmute yourself. State your name and please ask your question. Okay, hearing none, as we say in the courtroom.
Hello.
Yes.
Sorry I was late. Jim Roars here.
Oh, okay.
I understand. My statement was that they asked me to perhaps go through 2 MRIs. And I understand from your lecture now why they did that. I guess they're looking for the location of blood vessels.
Yeah, so I'll take a stab at that. Depending on who's ordering the MRIs, oftentimes your neurologist will order an MRI just to make sure there's not a structural reason in the workup of the Parkinson's disease. For example, such as a stroke or some sort of vascular malformation. So the neurologist may order one early on, but for your DBS, your neurosurgeon will also order a MRI with special protocols in it for surgical planning. As I mentioned in my presentation, I oftentimes get it with specific MRI sequences so that I can visualize blood vessels and also to visualize the specific targets. So that might be one reason why you were asked for multiple MRI scans. And in order to give you contrast, we have to check your blood level to make sure that your renal function or your kidney function is okay to get the contrast for the MRI.
Okay, thank you. I'm very pleased with your lecture so far. It's been very informative.
Thank you.
We are running over. There's another chat question. Ordinarily, I'd ask Tommy Liu, who sent it, to contact Dr. Lee, Darren Lee, who gave us this information, but it seems to be one of those foundation questions people would ask. So let me ask it in this case of Dr. Leiker. How long will DBS be functioning after implantation, knowing the battery is rechargeable? In other words, what's the effective life of a DBS implant?
Yeah, so it's kind of a two-part question because yes, the first question is just technologically, how long will the battery last? And the rechargeable batteries for Abbott are the non-rechargeable batteries for Abbott are 8 to 10 years. Is that the length of time, Jason? It varies with the amount of current that's being pulled for treatment. So the batteries can last quite a long time. The replacement of the battery procedure is a 15-minute procedure. So whether you decide on rechargeable or not rechargeable, you'll be well taken care of. Now, in terms of how long the DBS lasts, that's an interesting question because it really is dependent on the progress of Parkinson's disease itself. So there are elements of the disease that is adequately treated with DBS, for instance, the dyskinesias and tremor, rigidity, etc. And then there are elements of Parkinson's that are not adequately treated, like freezing and postural instability and the autonomic problems. And so those three, and probably Dr. Mason can add, but those three are not particularly well benefited by DBS, and so they will progress. So to the extent that DBS doesn't function or benefit the patient, you can expect that those effects of Parkinson's will continue to progress. We do have patients that are multiple decades out, 2 decades out from their DBS, and there's no question that they're benefiting to a dramatic degree because every so often the patient's batteries turn off. Sometimes they don't pay attention to the end of life warning, and patients need emergency battery revisions because they have a lot of difficulty when the batteries are not functioning. They really can appreciate the value of DBS and the symptom improvement when the batteries turn off. So I feel comfortable saying that DBS lasts forever. It doesn't give you the same benefit right after the surgery that you'll see 20 years after, but it helps many of the symptoms. And so it's really a life-saving technology, and we're pleased to offer it at USC.
Thank you. Dr. Brian Lee has indicated the telephone contact for the USC DBS program in the chat space. If you have not, click on that and you'll see the telephone number that's written there. Let me move on and wrap things up. Again, thanking our presenters for an outstanding program in my estimation, and I've heard many. Also, I want to thank all of our participants today from near and far who have listened in and participated, as I say, in what I think has been a good program. Mentioning again, this is the sort of thing that PCLA is unique in focusing on LA resources, of which we have many, and of which the Keck Medical School is a prominent one. And I also want to thank Abbott again for sponsoring this for PCLA and bringing our doctors to the program. An announcement, let me read it and stick my head down. Please join us on July 31 for a Let's Talk Parkinson's program on the, well, here it is, on the Ideal Parkinson's Diet, Strategies from the Dietitian, being presented by Jelena Adamovic. And you'll see, if you're on the PCLA email list, information coming up on events that are in progress, being listed, and which will occur pretty regularly throughout the year. As I said, and bears repeating, this event was brought to you by our sponsor, Abbott, and we are grateful to them for the support of our work and for their support of DBS innovation. And we also support you, our participants, our listeners, who have contributed to to PCLA over time. Your support has made these kinds of activities not only informational, but community support, outreach, support groups that we're known for, and for which we have many, many participants now. If you haven't donated yet, here's the information. Your donation certainly enhances what we can do and improves our mission for not only Parkinson's patients, but caregivers, of which I was one, as I said, and families in general. PCLA is a nonprofit organization. All donations, I want to tell you, are tax deductible. And if you enjoyed today's program, if you've seen programs from PCLA before, I hope you will either contribute for the first time or be a continuing contributor to PCLA's activities. And you could always reach PCLA at the email address at the bottom, info@pcla.org, as well as the telephone number. Thanks, everyone. Stay safe, particularly in these trying times, and stay well. And thank you for everyone who has participated. Good day.
Thank you. Bye-bye.
Thank you, everyone.
Thank you, everyone.
Bye-bye.